afternoon. I guess presbyopia is a very intriguing topic. First, we get Dr. Rohit Shetty, who's a master magician with technology and research work. He'll end up spinning the dishes for you, and then each speaker will come and share their experiences. And probably they do what they believe in is best. So in given situations, what would be my ace card is what I'll be discussing here. I'll be talking about presbyopic phakic IOLs, which is probably not the new kid in the block, but probably more so a new kid in the block because either most people are not doing it, or if they are doing it, not many people know about it. So I'll be sharing my experiences with that. Let's start. All of us, including me, are getting presbyopic. The biggest joke is my son was trying to install a video game in the laptop and he wanted to read the serial number and he was punching the keyboard. He says, "Papa, number pado." I said I couldn't. So he told me, "I think you need to show a good eye surgeon." So my son, when he said that to me, I realized what presbyopia means. See, as we age, accommodation declines, but our expectations don't. We still feel young, but our eyes don't match up with us. So I actually feel presbyopia in ophthalmology is the holy grail. And is presbyopic IPCL the missing link? Let's see. The best part about presbyopic IPCL is it's a reversible procedure. Can we reverse the relax or clear lens extraction? We cannot. Presbyopic LASIK, yes, maybe, maybe not. But this is one technology which I feel you can actually reverse for the patient. It all started with the phakic lenses, which were probably started from the anterior chamber. Then they came the posterior iris-supported lenses, and then the lens-supported lenses. So let's talk about lens-supported lenses. These lenses have been there for a very long time. Nearly more than 5 lakh lenses have been implanted all over the world. More than 20 years of track record proven, and it's a biocompatible acrylic material. Newer designs, newer materials, newer technologies are coming in. The lenses are getting thinner and thinner. The last lens I used was 80 microns thin. So the audience can actually imagine what is an 80 micron lens. So I'm using 80 micron lenses in my daily life. So when you do a prelex, are we ending up cutting something which we can save? I think so. We can save that. Especially when you do the prelex, you need to do the keratometry, the axial length, the formulas, the centration, the PCO management. That all is avoided when you do a phakic implant. All you need is a refraction, acceptance, anterior chamber depth, and white to white. So accuracy of prediction of IOL powers. Suppose you want to do a progressive correction in a patient who's a high myope, IOL formulas become an issue. Availability of the IOL power in PC IOL power in that patient is an issue. What are the advantages of doing a presbyopic IPCL? You retain the elasticity of the lens. That's what Dr. Rohit Shetty says. The lens is far more than a simple tissue which is focusing. It is an elastic tissue. Even I'm 49, 50 now, I can still read in good light. So why should I lose that if I go in for a prelex? Faster recovery because you've not cut the tissues open, you've done a capsular access. Size and power, any extreme is available in a progressive IPCL. You can go from 0.5 to -30, different sizes, toricities. It corrects your refraction, it corrects your astigmatism, and of course, it corrects your presbyopia. Now let's see some numbers which actually made me move towards this technology. I've actually done nearly 1,300 plus IPCLs. Over 900 were the V1 model, which was the earlier model. V2 model I've started using lately. I've fallen in love with this design. I've been using these lenses for over 4-5 years now. We've done 17 cases of piggyback for post-pseudophacus refractive error. That's when the idea came into me, and I talked to the company that we can have something like this. I had patients who were operated by some other surgeon, -5, -6, 2 years, 3 years old, capsular fibrosis. Now, do I explant? Do I do a LASIK? So I started putting IPCL in those patients, and these patients have started doing very well. So that's where the idea came of started doing, how about putting a multifocal presbyopic lens. Now 17 cases we've done of presbyopic IPCLs, 11 are secondary piggyback and 6 are primary. Now what are the issues I've faced in these 1,300 approximate cases? We explanted 4 cases. One was post-traumatic. The gentleman got injured while playing and he had a cataract. The lens needed to be explanted. The other 3 explants were not due to the lens, but it was bad sizing. Believe me, the lens will always bad vault. I call the word bad vault when your measurements are wrong. Once you get your measurements tight, this works like a beauty. No explants till now for halos or glare. No refractive surprises till date. We've never explanted a lens for a refractive surprise or a halo. We've only explanted due to rotation of the lenses or an excessive vault or crowding of the lens. The mainstay is if you can do your white to white accurately, anterior chamber depth and pupil size, you're ready to go. And you need a good refraction. So the advantage is you don't need an expensive equipment like a LASIK. So then we had good experience with the technology of multifocus from this company. The huge track record of nearly 4,000 lenses used till now. We've used trifocals, we've used toric multifocals, toric trifocals. The list goes on and on. So I realized that this was a good combination. So I've used an IPCL and I've used a progressive or a multifocal lens or a trifocal lens on a same platform. So how about joining these two? That's when the idea came of started using progressive lenses. So did we have any issues with the multifocal lenses? There were no decentrations. Yes, PCOs were there, negligible glare and halos, available in smart toric, which means you didn't need to dilate them. And then of course the trifocal lenses are available, which is the new kid on the block. So this is a photograph of the toric. You can see the PCO, but you see that the centration. The best part of these lenses is you have to just center them at 0-180. Even if there's astigmatism, you center them at 0-180. So you don't need to dial them. That's a big plus point. So much so, even my femto cases, I've started using these lenses with toricity or non-toricity. Now coming to the presbyopic IPCL. Now what is confluence? There's a confluence of a multifocal or a trifocal technology, toricity, and a phakic lens, all joining together to form the presbyopic IPCL. What are the contraindications? Of course, if your patient has lenticular changes, he's an age group where he's getting cataract, even a peripheral cataract, he's not a candidate because very soon you'll be doing a cataract. So go ahead and do a clear lens extraction in him. Convergence issue, as Dr. Rohit said, if the patient has some convergence issues, avoid them. Very large pupils, avoid them. Pupils which don't dilate properly, avoid them because putting in the phakic lens will be tricky. Anterior chamber depth less than 2.8 millimeters, history of recurrent uveitis, macular pathologies, corneal abnormalities. Cycloplegic refraction is very important when you're planning to do a progressive phakic lens. Anterior chamber depth is the cornerstone. Two important things if you have to master when you're doing a progressive phakic lens or a phakic lens is an accurate anterior chamber depth measurement and an accurate white to white. I have a special session on this, but I don't think the topic will be able to cover that. But what I would recommend is take the mid-limbus. Take the mid-limbus, don't go at the edge. It's a bad idea to use an infrared image, and if you use an infrared image, never take the machine's reading, zoom on the image and do a manual correction. So this is what I mean by the mid-limbus. You can use an OBSCAN, Cirrus, Pentacam or a UBM, but the values will be different. A UBM will give you a bigger white to white. A Pentacam is known to give you a more white to white than actual by 0.38, so nearly you will get a 0.4 bigger. I am very happy doing it on a Cirrus and a Pentacam, or I use a caliper also. All you need to do is get your white to white, add 0.75 to it, and that's the size of the IPCL you should be ordering. If your AC depth is more than 3.1, order 1 millimeter on top. So let's say if your white to white is 12 millimeter, AC depth is 3 millimeter, order a 13 millimeter. But suppose your AC depth is more than 3.2, you can go by 1.25 more. That gives you a very good vault. Again, no high-end surgical equipment is required. You don't need LASIK machines. You don't need high-end equipment for that. The presbyopic IPCLs are available in 1.5, 2, 2.5, 3, 3.5. One of my first patients was my OT technician. I'll share the story. Now they are available in powers of 0.5, which means if you have a patient who's 50 years old and is -6, you can correct his -6 and you can also correct his presbyopia in one go, and this procedure is totally reversible. Another thing you can do is, let's say his patient is -6 with -2 cylinder. You correct his cylinder, you correct his spherical error, and you correct his presbyopia. So you will have combinations available, different sizes according to the white to white and pupil sizes available. Patient selection criteria, this is recommended by the company. I do my own tweakings sometimes in between. I usually go for a unilateral implant and I let the patient be for some time. I don't rush into it. Earlier, first few cases I was rushing into it. I let the patient use it in a non-dominant eye. I give an ad of 0.3 more than the patient requires. Let's say the patient requires 1.5 ad, I put a 2 diopter lens. What that does for the patient is it gives him an extra depth. He starts relaxing his accommodation, whatever he has, so that goes back to the reserve. And then he has an extended period. I give him 2-3 weeks. If he's happy, he doesn't complain of any other issues, the vaulting is fine, everything is fine, then I go ahead and put in the bilateral. But if the patient says, I'm very happy with one eye, I'm actually doing work and I don't think I need the second eye, we just do one eye and let the patient go. Now, what are the tests you need to do? Gonioscopy is very, very important to check the angle crowding. Do an anterior segment OCT to see the iris insertion patterns. 6/6, if both eyes are there, use the non-dominant eye first. And one thing I've realized is it works best in pseudophakic patients. And just imagine what has happened is, all the patients whom you have done cataract for, it was like an account closed for you. Both eyes operated, account closed. Checkbook torn, passbook torn. Now you have another credit card. Now you can offer these patients presbyopic correction. Irrespective whether they have a distance refraction or not, you can start offering them. So I've started doing that now. Most of my patients are in this category now. Patients who've met somebody where I've done a multifocal primary implant, but I've operated them 5 years ago with a monofocal. And they say, Doctor Saab, mera hi ho sakta hai? I say, ho sakta hai, we'll do some tests for you. We do it one eye. If he's happy, don't do the other eye. But if he says, Doctor Saab, I want the same in other, so we do it with the other eye also. So it works beautifully. There's a patent filed on this in USA. This, I'll just show a video of, this was the first implant I tried in an ambulopic patient. I didn't want to take risk. So this is an implant in a, this was a patient who was ambulopic, so there were no big issues. I just took my chance. I said, let's see how he does. The patient's best corrected vision was 618, 612 parts. We did the lens. We corrected +6 and gave him a +1.5 ad. And the patient was happy. So that actually encouraged me. Then the next patient I did was my OT technician. I did my OT technician in a live surgery in DOS. So what the problem was, he started, I had operated cataract for him 5 years ago. And he used to fumble at times trying to bend my capsule rhexis needle or trying to load the lens. So he's a very old OT technician in the OT. So one day he said, sir, आप live surgery में लोगों का करते हो, ये अगर आप अच्छा lens है मेरे को डालोगे? I said, okay, I'll do one eye. So one eye I did in the live surgery. And 3 days post that, he started assisting me in the OT again. And he said, sir, I can see, but it will be good idea if you do the second one. So once I did the second eye, and his assisting me really improved. That gave me courage that if my OT technician who needs to do fine work is feeling better, so I started offering the secondary piggyback in my pseudophakic patients as an open thing. So when a old patient walks in for a review for some other problem, my counselor tells them, sir, we have a technology, if you want, we can offer you. Some of them say, okay, we'll take time, they take back the brochure, they go back, sometimes they come back. So now we've started doing that. This is the first patient we did. So it's a proprietary design, advantage over Prelex, which I did say, predictability of correcting the refractions, the risks of doing open surgery with taking the cataract out, the PC rent, and the other chances of having tear extension. Suppose you plan a multifocal lens, a simple lens in this patient, and the rhexis gets torn out. You're stuck up. You've taken the lens, crystalline lens out, and you cannot put the regular lens, multifocal in. Now what do you do? So these are situations you can land up with Prelex. Extreme powers are available till -29. So this is the summary. There are innumerable papers coming in the market, and peer literature are reporting about it. So most of the people are happy. Okay. So thank you.